Acute spinal cord injury. Phases of acute spinal cord injury. Injury to the spinal cord results in three physiologically distinct phases. Hypertension. This starts almost immediately. There is massive catecholamine release due to direct stimulation of the spinal cord, which causes hypertension and tachycardia. This may result in myocardial ischemia, cardiac failure and pulmonary edema, neurogenic shock. This stage follows rapidly and lasts for several weeks, most commonly seen in lesions above T6. Disruption of autonomic pathways below the level of injury results in hypotension, due to loss of sympathetic tone, and bradycardia if the cardiac accelerator fibers at T1, T4 are affected. Premedication. Unopposed vagal tone may result in severe bradycardia or even asystole during procedures such as laryngoscopy and tracheal suctioning. Premedicate with anticholinergics. The patient will be hypotensive, but peripherally warm and vasodilated. Excessive fluid administration can result in pulmonary edema, and early use of vasopressors should be considered to maintain organ perfusion. Spinal shock. This phase accompanies neurogenic shock and commences at the time of injury. It initially consists of flaccid areflexia with loss of sensation and motor paralysis. A four-phase course is described, with reflexes beginning to return 1D after injury and achieving a hyperreflexive, spastic state after 71Y. Autonomic dysreflexia is a life-threatening manifestation of this hyperreflexia. See below. Autonomic dysreflexia. Autonomic dysreflexia is a potentially life-threatening condition characterized by an inappropriate autonomic response to a stimulus below the level of the spinal cord lesion. Incidence. It is seen in up to 50 to 70% of patients with a spinal cord injury at or above T6. The incidence is greater with higher lesions and complete cord injury. It may occur as early as 3W following the initial injury. Pathophysiology. Activation of the sympathetic chain causes intense vasoconstriction and subsequent hypertension, compounded by loss of descending inhibitory control due to cord injury. Features include hypertension, headache, flushing, sweating and anxiety. Common precipitants include pain, bladder distension, urinary tract infections, catheter insertion and fecal impaction. Complications. Life-threatening hypertension can cause cardiac emergencies, including myocardial ischemia, arrhythmias and pulmonary edema. Neurological complications are also possible, including seizures and intracranial hemorrhage. Management. Determining the cause of the autonomic dysreflexia and managing the consequent hypertension. Exclude bladder distension and constipation, and search for trigger, sublingual GDN or nifedipine 10 mg, or slow IV hydralazine 20 mg. If hypertension persists, IV GDN, phentolamine or magnesium may be used. Management acute senkel syntoniate, therclespine. Damtf penal canal is thuothsrace la cephalian. Conduct of anesthesia in patients with chronic spinal cord injury. Key considerations. 1. Previous anesthesia. Review previous anesthetic charts. 2. Autonomic dysreflexia. Consider invasive BP monitoring, especially with significant fluid shifts. 3. Airway management. Laryngoscopy may be difficult due to cervical fixation. 4. Regional anesthesia. Spinals and epidurals can reduce postoperative ventilation and autonomic dysreflexia. 5. Upper limb surgery. Carefully consider risks of brachial plexus block in patients with impaired respiratory function. 6. Gastric emptying. Consider rapid sequence induction RSI, due to delayed gastric emptying. 7. Respiratory function. Prolonged ventilation and tracheostomy can lead to respiratory complications. 8. Autonomic dysreflexia history. Carefully explore history and plan accordingly. 9. Cardiovascular disease. High index of suspicion for cardiovascular complications due to accelerated atherosclerosis. 10. Thermoregulation. Consider temperature probe due to impaired thermoregulation. 11. Osteoporosis and skin care. Meticulous positioning in skin care to prevent pressure areas. 12. Chronic pain, tailored perioperative analgesic regime involving acute and chronic pain, Teams 13. VTE prophylaxis, high risk of VTE, consider mechanical and/or pharmacological, thromboprophylaxis, postoperative care. 1. Positioning, patients with injuries at the cervical level should be recovered in a supine position to optimize respiratory function by maximizing diaphragmatic excursion. 2. Autonomic dysreflexia. Autonomic dysreflexia may occur due to pain from the surgical site or other common triggers. 3. Respiratory function. In cervical and upper thoracic lesions, respiratory function will be suboptimal and the risk of postoperative pulmonary complications is high. Consider elective postoperative respiratory support, obstetric anesthesia in patients with spinal cord injury. 1. High-risk pregnancy. Obstetric patients with chronic spinal cord injury are at increased risk of preterm delivery, thromboembolism, sepsis, and cesarean section. Assessment in an obstetric anesthetic clinic is highly advisable. 2. Respiratory function. The gravid uterus can affect respiratory function in patients with high thoracic cervical injuries, requiring increased respiratory support and regular measurement of vital capacity. 3. Neuraxial anesthesia. Spinal anesthesia can usually be cited, but epidural anesthesia in areas of spinal fusion may result in failure, dural tap, or inadequate block. An alternative plan should be considered. 4. Autonomic dysreflexia. Patients with a history of autonomic dysreflexia should be closely monitored, and epidural analgesia is the most effective way to prevent it. 5. Labor and delivery. Patients with lesions above T may tend not feel contractions, but contractions can trigger autonomic dysreflexia. Consider citing an epidural prior to induction of labor. 6. Differential diagnosis. Preeclampsia should be considered as a differential diagnosis to suspected autonomic dysreflexia. 7. Patient positioning. Patients have exaggerated postural hypotension and tolerate aortocaval occlusion poorly. Great care must be taken with patient positioning. 8. Postpartum care. The contracted uterus may still act as a trigger for autonomic dysreflexia. Consider leaving the epidural in situ for up to 48 hours. Postpartum autotransfusion of blood from the contracted uterus may cause pulmonary edema and respiratory failure in patients with cervical lesions. Pituitary surgery, transsphenoidal SX, procedure transsphenoidal hypophysectomy. Time 90-300 minutes. Pain ++, position, supine, head up tilt, blood loss, nil usually, but large if venous sinus disrupted, GNS, practical techniques, IPPV, arterial line. Pituitary tumors account for 10 to 15% of all intracranial tumors. They present with hormone hypersecretion, acromegaly, Cushing's disease, prolactinoma, thyrotoxicosis, hormone hyposecretion, adrenal insufficiency, hypothyroidism, diabetes insipidus, mass effects headaches, visual field defects. Hydrocephalus. Hypophysectomy is undertaken urgently if the patient's sight is deteriorating rapidly. Preoperative, special considerations for acromegalic patients, possible airway compromise due to macroglossia. Prognathism and hypertrophy of the epiglottis vocal cords. Advanced airway techniques may be required: videolaryngoscopy, AFOI, hypertension, LVH, IHD, cardiomyopathy, OSA in up to 70%, DM and other endocrine pathology, special considerations for Cushing's patients. Hypertension, truncal obesity, OSA, electrolyte abnormalities, hypokalemia, glucose intolerance, DM, higher risk of perioperative thromboembolic disease, steroid cover necessary pre- and postoperatively, perioperative. As for craniotomy, invasive arterial monitoring generally advised. A throat pack should be inserted following intubation to reduce laryngeal soiling. A topical vasoconstrictor, e.g., Moffitt's solution, may be instilled into each nostril to improve surgical conditions. Surgical access is via the sphenoidal air sinuses, if there is suprasellar extension. A lumbar drain can be inserted into the CSF. The anesthetist may be required to instill a volume of sterile 0.9% sodium chloride to advance the tumor into the operative field. Major hemorrhage may occur if there is disruption of the cavernous sinus carotid arteries, which are lateral to the pituitary gland. Postoperative, diabetes insipidus may occur within 12-24 of surgery, in up to 50% of patients. It is managed initially with IV desmopressin, 0.25 to 1 micrograms. Can be given PO subsequently if required. Cerebrospinal rhinorrhea may occur. It is usually self-limiting, but if persistent, intermittent, CSF drainage via lumbar drain may be required. Occasionally, surgery to repair the CSF leak is required. Special considerations: patients with preoperative panhypopituitarism or who develop post-operative endocrine disturbances should be referred to an endocrinologist for advice on hormone replacement. If a craniotomy is planned, rather than a transsphenoidal approach, refer to P561-62. Venous air embolism. V is the entrainment of air into the venous circulation, leading to systemic effects. The volume of air entrained to cause significant injury is unknown but estimated to be 3-5 ml/kg in adults. The greater the rate of entrainment, the smaller the lethal volume. V can occur whenever the operative site is higher than the right atrium. Its incidence is particularly high during craniotomy in the sitting position and when the surgeon is dissecting tissues that do not allow veins to collapse despite a negative pressure within them, e.g., the emissary veins in the posterior fossa. There are three main consequences of V: pulmonary microvascular occlusion, resulting in an aphysiological dead space, hypoxia and pulmonary edema, air bolus, larger volume causing obstruction to RV ejection, leading to pulmonary arterial hypertension and RV failure. Paradoxical air embolism, see below. Signs of V depend on the rate and volume of air entrained and include decrease in ETCO2, bronchoconstriction, hypoxia, arrhythmias, myocardial ischemia, hypotension and cardiac arrest. N20 does not increase the risk of V but may worsen its outcome. Detection of venous air embolism. ETCO2 is generally the most useful monitor, as it is widely available and sensitive. Air embolism results in a sudden reduction in ETCO2. Hyperventilation, low CO and other types of embolism will also result in ETCO2 reduction. Doppler ultrasound uses ultra-high frequency sound waves to detect changes in blood flow velocity and density. It is the most sensitive non-invasive monitor. However, it is not quantitative and does not differentiate between a massive or a physiologically insignificant air embolism. TOE is the most sensitive and specific monitor, but is invasive and difficult to place, and needs expertise to interpret. However, it can detect as little as 0.02 ml/kg of air. PA catheters are invasive, but sensitive monitors for V. However, an increase in PAP is not specific for air and they are very rarely cited. The least sensitive monitor is a precordial or an esophageal stethoscope to detect a millwheel murmur. This is apparent only after massive V, which is usually clinically obvious. Prevention: avoid the sitting position, unless essential, elevate the head only as much as necessary, ensure adequate blood volume to maintain a positive CVP. Small amounts of PEEP may reduce the risk of air entrainment, although, controversial, medical anti-shock trousers may be used to increase VP and reduce hypotensive episodes in patients in the sitting position. Identify susceptible patients. If risk factors cannot be mitigated, treatment, supportive, inform the surgeon, who should flood the operative field with fluid. This stops further entrainment of air and allows the identification of open veins that can be cauterized or waxed if within bone. If possible, position the operative site below the level of the heart to increase VP. Stop N20 immediately if used, and increase the Phi02 to 1.0. Consider increasing PEEP. With patent foramen ovale, support the BP with fluid and vasopressors. Attempt to aspirate air from the CVP line. The tip should be placed close to the junction of the SVC and the right atrium, and ideally confirmed radiologically prior to surgery, if a large volume of air has been entrained and surgical conditions permit. Turn the patient into the left lateral decubitus position to attempt to keep the air in the right atrium, or alternatively the Trendelenburg position. There is little evidence for this. Commence CPR, if necessary. This may break down a larger air bubble, a paradoxical air embolism. Air emboli may enter the systemic circulation through the Thebesian veins in the heart, the bronchial vessels, or a patent foramen ovale. Such defects may be small. Small volumes of air in the systemic circulation can have disastrous consequences, resulting in temporary or permanent symptoms of CVE or ischemia of other organs. Intracardiac septal defects are an absolute contraindication to surgery in the sitting position. This should be screened preoperatively in high-risk cases. Summary: venous air embolism, sequelae of V, signs of V, detection of venous air embolism, prevention, treatment. Temperature control. Core body temperature in an awake patient is tightly controlled between 36.7 degrees Celsius and 37°-31 degrees Celsius. Deviation above or below these temperatures causes the hypothalamus to initiate behavioral and autonomic mechanisms to restore normothermia. This tight regulation is lost under GAN neuraxial anesthesia due to drug-induced vasodilation, abolition of behavioral responses to thermal discomfort. Temperature control. Core body temperature in an awake patient. Temperature control. Core body temperature in an awake patient is tightly controlled between 36.7 degrees Celsius and 37°-31 degrees Celsius. Deviation above or below these temperatures causes the hypothalamus to initiate behavioral and autonomic mechanisms to restore normothermia. This tight regulation is lost under GAN neuraxial anesthesia due to drug-induced vasodilation, abolition of behavioral responses to thermal discomfort, and resetting of the threshold temperatures in which autonomic responses are activated, resulting in a widened range. The anesthetized patient is prone to hypothermia defined as core body temperature 36 degrees Celsius. This typically occurs in a triphasic pattern. Phase 1, rapid loss of 71 degrees Celsius within the first 30–45 minutes of anesthesia due to heat distribution from the core compartment to the peripheries. Phase 2, loss of 71 degrees Celsius over 2–3 from radiation, 40%, convection 30%, evaporation 25%, and conduction 5%. Phase 3. A plateau occurs when heat loss is finally matched by heat production as maximal vasoconstriction is activated. Hypothermia in the perioperative period is not benign. Adverse consequences include coagulopathy and an increased need for transfusion, increased risk of surgical site infection, increased rate of MACE, reduced rate of drug metabolism, e.g., prolonged NMB, and delayed emergence from anesthesia. Measures to reduce the risk of perioperative hypothermia include identifying high-risk patients, high ASA grade, low BMI, undergoing major surgery, and using a combined general neuraxial technique, and treating hypothermia before commencing anesthesia, monitoring core body temperature, distal esophagus, nasopharynx, tympanic membrane or bladder at 30 minutes intervals, maintaining ambient temperature in pre-op areas and operating theaters. Pre-warming fluids, to 37 degrees Celsius for IV administration or internal irrigation, and humidifying respiratory gases using an HME filter. Active cutaneous warming, most commonly achieved using a forced air device, which should be used for all procedures with anesthesia time, 30 minutes. Active internal warming techniques, such as CPB and peritoneal lavage, are invasive and therefore are not indicated for most routine operations. Clinical considerations for bispectral index, BIS calculation. EEG data is processed through several steps to calculate a single number correlating with anesthesia depth. BIS values 65–85, sedation 40–65, general anesthesia. Limitations of BIS studies. Initial studies were observational, underpowered, and not masked. Cost and effectiveness. Monitor costs several $1,000s. Single-use electrodes cost $10–15 per anesthetic. Some patients with awareness had BIS 65. Questioning its value. Detecting awareness. Post-operative questioning can identify potential awareness events. Ask patients to recall events before, during, and after anesthesia. Managing awareness, close follow-up and mental health expert involvement can prevent traumatic stress. Patients under regional anesthesia and propofol sedation may recall events and should be informed. BIS and outcomes. Some studies suggest triple low BIS, blood pressure, and anesthetic concentration increases hospital stay and mortality, but others have found no association. Awareness. Julian Barker. You are called to see a patient on the surgical ward